The initiation for contraction for cardiac muscle differs greatly from that of skeletal muscle. You'll recall from A&P1 that skeletal muscle required nervous impulse from a motor neuron at the myoneural junction in order for contraction to occur. Cardiac muscle is unique in and of the fact that it displays a property known as autorhythmicity. Autorhythmicity is basically the ability for the heart to generate electrical signals that make the heart contract without the help of nerves. Within the heart, there are two types of cells. There are specialized cells known as cardiac conducting cells or pacemaker cells, and this makes up only about 1% of all the cells within the heart. They produce a cardiac conduction system which includes these specialized cells in certain areas, including the sinoatrial node or SA node, the atrioventricular node or AV node, the bundle of His, bundle branches, and Purkinje fibers. Again, these specialized cells, pacemaker cells or cardiac conducting cells, will initiate and propagate action potentials without the external help from nerves. The remaining 99% of cells within the heart are contractile cells, so they are going to help continue to conduct the impulses, and by doing so they are able to contract as a unit or functional syncytium, and they can help continue the impulse conduction because where those muscle fibers are connected at the intercalated discs, we have those special gap junctions which are going to allow the ions to flow from one cell to the next, and that allows the atria to contract as a unit and the ventricles to contract as a unit. So we see atria ventricles pause, atria ventricles pause, atria ventricles pause. That's the functional syncytium, when the atria contract together and the ventricles contract together. Now, before we go into more of the electrical activity, I just want to look at the metabolism of cardiac muscle. Because the heart has to beat 24 hours a day, 7 days a week, the metabolism of the cells within the heart is going to be based on aerobic metabolism, and the mitochondria are not only going to be using oxygen, but they're going to be requiring the constituents of carbohydrates and lipids in order to have the pieces parts they need to put together enough adenosine triphosphate for the heart to continue to beat. And when it comes to the contraction of contractile cells, they tend to have twitch type contractions that involve long refractory periods, brief relaxation, and that allows for the chamber in the heart. So we've got 4 chambers, so the chambers can refill, and it also prevents tetanic contractions from occurring. Next, we're going to dive into the cardiac conduction system. Now, you'll remember from a few slides ago that there are 2 types of cells within the heart. There are conduction cells or pacemaker cells and cells that contract. They're called contractile cells. And what's kind of cool is that if we were to take some embryonic heart cells and put them in a petri dish, the conducting cells that set a faster pace for contraction would affect all the other cells in the dish, and they'd all start contracting at that faster rate. And the same mechanism is true in fully developed hearts. At this point, you might be wondering, well, how do cardiac conduction cells or pacemaker cells self-depolarize without the input of a neuron? Well, Cardiac pacemaker or conduction cells are able to do this because they don't have a stable resting membrane potentiation like we see in neurons. In fact, they have sodium channels that allow sodium to leak in slowly, and that takes them from a value of negative 60 millivolts towards threshold, which is negative 40 millivolts. And with that slow influx of sodium, we call that the prepotential. Once we hit negative 40 millivolts, we've reached threshold, at which point calcium voltage-gated channels open, allowing depolarization to occur because of that rapid influx of calcium. And books will vary on the values of these membranes. Some books say that the depolarization of cardiac conduction cells will go all the way up to 0, or some go even beyond that to 12 or 15 millivolts. Once that depolarization has reached its peak, the calcium voltage-gated channels will close and potassium voltage-gated channels open, allowing for positive potassium to go back out, repolarizing the membrane down to about negative 60 millivolts. It doesn't stay there though. It continues to drift towards threshold because of those sodium channels that allow sodium to leak in slowly, taking that threshold, taking the membrane from negative 60 to threshold at negative 40 millivolts. And this explains how cardiac conduction cells are self-exciting, and because this happens on a regular interval, they're autorhythmic as well. And this spreads impulses throughout areas of the heart, so those chambers of the heart can contract in a manner that is both orderly and sequential without the input of nerves. The cardiac conduction system starts with the sinoatrial, or SA node, which is located in the right atrium, just inferior to the opening of the superior vena cava at the right atrium. And this sinoatrial node is what establishes normal cardiac rhythm and is often referred to as the pacemaker of the heart. The rhythm that it starts is often referred to as sinus rhythm. The sinoatrial node can spread impulses to other areas by way of 3 bands. There are anterior, middle, and posterior internodal pathways, and those spread impulses from the right atrium to the left atrium, as well as to the atrioventricular node. So on this picture, you'll notice that number 1 is what indicates the right atrium, and the SA node, which you can see just below the number 1. And number 2 is indicating how the excitation is going to spread through the myocardium of the atria. And number 3 is where we have the atrioventricular node. At the atrioventricular node, there is a critical pause of the spread of electricity, and this occurs because there are fewer gap junctions at the atrioventricular node and the fibers are smaller. And this pause is really important because it allows the cells of the atria, the contractile cells, to completely contract before the impulse reaches the ventricles, causing the ventricles to contract. Because remember, we need the atria to contract first, and then the ventricles. And then there's going to be a pause. So it goes atria, ventricles, pause, atria, ventricles, pause, atria, ventricles, pause. So when we look at the events of the cardiac cycle or the cardiac conduction cycle, we can see that if we look at the very top of this picture where it says start, you can see the purple, and we see the beginning of the P wave on the graph for the EKG, and that P wave is where the atria depolarize. And then after that atrial depolarization, we have contraction, because we have to have depolarization and then contraction. So the P wave is the depolarization of the atria, followed by atrial contraction, which occurs after the P wave. After the electrical impulse has gone through the atrioventricular node, it will then travel to the atrioventricular bundle, otherwise known as the bundle of His. This bundle is located at the superiormost portion of the interventricular septum, which is that wall that separates the right and left ventricles. This bundle splits fairly immediately into right and left bundle branches, which will innervate the right and left ventricles accordingly. Now, between the atria and the ventricles, there's a fibrous cardiac skeleton that insulates the atrioventricular junction and is non-conductive. And so even though the atria and the ventricles are adjacent, they're next to one another, they're not connected to one another by way of gap junctions, and the atrioventricular bundle is the only electrical connection that exists between those two. When we look at this picture, you can see, again, we'll start at the top. We've got the P wave, which is atrial depolarization. You can see the purple where they're starting to depolarize. After that small P wave, the next picture is showing atrial contraction. And then as the electricity spreads down the bundle branches, you can see the beginning of the Q wave. And then we're going to continue to the next slide. As the right and left bundle branches are going to arise from the atrioventricular bundle, traveling down the interventricular septum, they're going to go towards the apex of the heart, which they can then excite. And coming off of the bundle branches, we have special fibers known as Purkinje fibers, which are going to branch off, extending not only into the apex, but also turning upwards superiorly into the walls of the ventricles. Now, since the left ventricle is larger and has to create a bigger force to pump blood throughout the body as opposed to the right ventricle, which is only pumping blood to the lungs, the left ventricle has a much more extensive network of fibers. And the gap junctions are critical throughout the myocardium for continuing the spread of depolarization. Here we can see the rates of firing. The cardiac conduction cells within these structures don't actually fire at the same rate, even though they self-depolarize. They don't fire at the same rate. The sinoatrial node, with no intervention whatsoever, will depolarize anywhere between 60 to 100 beats per minute, the average being about 75. Those cells reach threshold fastest. It's because of parasympathetic tone from the vagus nerve that the heart rate normally decreases to about 70 beats per minute. The atrioventricular node is capable of depolarizing anywhere between 40 to 60 beats per minute. So if there were no parasympathetic innervation to slow the heart down or sympathetic innervation to speed the heart up, and if the SA node were not functioning, the AV node would cause the heart to beat anywhere between 40 and 60 beats per minute. And the atrioventricular bundle, or the bundle of His, is capable of depolarizing at 30 to 40 beats per minute, and then the Purkinje fibers, also known as the subendocardial conducting network or subendothelial conducting network, they can depolarize at 15 to 20 beats per minute. So usually if the heart rate is less than 50 beats per minute, that's what we determine as being slow or bradycardia. Okay, bradycardia is a slow heart rate. Tachycardia, T-A-C-H-Y, cardia, is a heart rate that's too fast. And at 50 beats per minute, the heart is not beating fast enough to effectively pump blood, and that's where normally with most people we see loss of function, because we're not getting enough perfusion, we're not getting enough oxygen to important tissues like the heart muscle, like the brain, and other important organs to help us maintain homeostasis. So if we look at this picture, we see it, number 1, pointing to the sinoatrial node or SA node. That's known as the pacemaker of the heart. It generates a sinus rhythm. Number 2 is pointing to the atrioventricular node. Remember, there's a pause of about 1/10 of a second from the SA to the AV node, or that occurs at the AV node. And then the impulses will continue at the AV bundle, the bundle of His, which connects the atria to the ventricles. And then the bundle of His splits off into right and left bundle branches. Clinically speaking, if you ever hear of a bundle branch block, that means that one of those bundle branches is not conducting electricity the way it's supposed to. And then we have the subendocardial conducting network consisting of Purkinje fibers, and also you may hear the term subendothelial conducting network. You'll remember from A&P1 that in order for skeletal muscle to contract, we had to have an impulse coming from a nerve in the form of an action potential, which in turn depolarized the sarcolemma of the skeletal muscle fiber in order for other events to allow for contraction to occur in that skeletal muscle fiber. We already saw cardiac conduction cells, which are going to generate impulses on their own at frequent intervals, and those will affect the cardiac contractile cells, which make up about 99% of all the cells within the heart. Cardiac contractile cells are different from conducting cells because they have a very rapid depolarization that's followed by a plateau phase, and then we have repolarization and extended refractory periods, which will help not only provide tetanic contractions but also premature contractions that could lead to inefficient pumping. So when we look at the membrane potential in the cardiac contractile phase, let's look at the fact that the membrane potential of cardiac contractile cells is going to begin at -90 millivolts, and with the impulse generated by cardiac conduction cells, that will take the membrane from -90 to threshold very quickly, and this will cause the opening of sodium voltage-gated channels. Now remember that sodium, when those voltage-gated channels open up, sodium is coming inside the cell, just inside the membrane. And at positive 30 millivolts, those sodium voltage gated channels will close. And potassium voltage gated channels that are slow are going to open up, and that's what causes this initial slight repolarization. It's from the efflux or outgoing of potassium. All the players in this are positive cations. However, because of the change in the voltage on the membrane of cardiac contractile cells, we're also going to see slow calcium channels open, and calcium will come inside, just inside the membrane. That helps to maintain that positivity of the cardiac muscle membrane, which causes a plateau. Eventually, those slow calcium channels will close, and we'll see more of an efflux or outgoing of potassium. And I'm going to take my camera off if I can. There we go. So we're looking at a myocyte in the picture down below, and we can see that, and I've tried to align this little graph down below in the myocyte. Okay, so we're looking at a myocyte, a muscle cell, a cardiac muscle cell. And so we can see the depolarization coming from the influx of sodium. There's a little bit of efflux of potassium, which causes that little dip up at the top. And then we have another influx of cations. This time we've got calcium coming in, and that keeps the membrane at a more positive level, causing that plateau. And eventually calcium channels are going to close, and so no more calcium can come in, but as the potassium channels are now open, we have more potassium leaving, going out. That makes the membrane more negative, and it helps to repolarize. And again, this allows for a longer absolute refractory period, and that helps us avoid tetanic contractions. And we do have a short relative refractory period that can allow for premature contractions, but if everything is working correctly, that will not occur. Okay? We saw earlier in this presentation a little bit of an electrocardiograph. An electrocardiograph is the written representation of the electrical activity of the heart, and an electrocardiogram is the actual instrument used to record this activity. The term electrocardiogram was originally a German word, and that's why in German cardio begins with a K, and people used to say that they needed an EKG rather than an ECG. You may still hear either term. They're both used interchangeably, and either one is correct. The electrocardiogram utilizes special recording electrodes known as leads, and according to the information that a person wants to get, either 3, 5, or 12 leads can be used. Obviously, the greater the number of leads, the more accurate the assessment can be retrieved from the machine. When we look at the EKG or ECG, you'll remember that the P wave that we see here is indicative of atrial depolarization. The QRS complex is indicative of ventricular depolarization. And you notice that the depolarization of the ventricles is much stronger than it is of the atria. And contraction of the ventricles actually begins at the peak of the R wave. The T wave is indicative of ventricular repolarization. So we see these electrical events on the ECG. Sometimes an area of the heart other than the sinoatrial node will generate an impulse that will be followed by premature contraction. And this area, which may either be a component of the electrical conduction system of the heart or some other contractile cells, is known as an ectopic focus or ectopic pacemaker. The term ectopic means outside of, and an ectopic focus may be stimulated either by localized ischemia, which is lack of blood flow to an area. It could be stimulated by exposure to certain drugs, including caffeine, digitalis, and digitalis is a drug that actually allows the heart to pump more efficiently, as well as allow blood to flow more efficiently through the body. But too much of anything can be harmful as well. So too much digitalis or acetylcholine, sometimes even elevated stimulation by the sympathetic or parasympathetic divisions of the autonomic nervous system, as well as a number of disease processes, can cause an ectopic focus to occur. Now, if this is an occasional event, it's not going to be an issue. However, if the condition becomes chronic, it can lead either to an arrhythmia, which is an abnormal heartbeat, or it could lead to fibrillation, which is when the chambers of the heart are beating out of sync. So let's take a look at the pictures that we have here on this PowerPoint slide. That one at the top demonstrates a second degree or partial block of the atrioventricular node. And when you look at this graph, notice how half of the P waves aren't followed by the QRS complex and T waves, but the other half are. So half are, half aren't. And how does this present clinically? Well, a patient who has a second degree partial block of the atrioventricular node will usually demonstrate bradycardia, which books disagree on. Some say it's less than 50 beats per minute, some say it's less than 60 beats per minute. It's going to be a slower pulse. If we look at the picture of the graph below in atrial fibrillation, you're going to see how there's an abnormal electrical pattern just before the QRS complexes. And you'll notice that the QRS complexes are occurring at a much faster rate. So we've got the atria that are going blah, 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 ventricles, atria, blah, 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 ventricles, atria, blah, 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 ventricles. And a patient who has atrial fibrillation will demonstrate having an irregular and fast heartbeat. With the ventricular tachycardia that you see in the middle, you're going to notice that there's an unusual shape to the QRS complex, and also the S is really loopy and then it's kind of funny looking. So with ventricular tachycardia, that person's going to have a rapid heartbeat of about 100 beats per minute, followed by 3 normal heartbeats in a row. So it goes rapid, 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 rapid for 100 beats, and then 3 normal ones, and then rapid, 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 and then 3 normal. When we look at the graph below for ventricular fibrillation, now the ventricles are beating really rapidly out of sync. So we have atria, ventricles, ventricles, atria, ventricles, ventricles. And so because the ventricles are depolarizing so quickly and so often, that's all we see is this massive lines, because the QRS complex is going to override any other thing that's done by the atria, and especially at this point because it's going so quickly. So with ventricular fibrillation, we have a very fast, uneven pulse. Sometimes it will be absent, and this pulse may be going as high as 300 to 400 beats per minute. So it may be going so fast that you can't even detect the pulse if you're using your fingers to try and feel it. At the very bottom, we've got an example of a third degree block, also known as a complete heart block at the atrioventricular node. And with this one, I'm going to take me out of here for just a second. so you can see that a little bit better. You'll note that some of the impulses initiated by the SA node, the sinoatrial node, don't even reach the AV node, while others do. And the P waves aren't necessarily followed by a QRS complex. So when we look at this, we see just a little bit on the graph, and the person who has this is going to present with a very, if you can feel the pulse, it will be very weak, very slow, sometimes referred to as being thready, and so it's so light that it's barely palpable. It'll be usually less than 50 beats per minute or even absent. So that is a third degree block. Now, only with ventricular fibrillation and ventricular tachycardia and atrial fibrillation can we use an automated external defibrillator to deliver a shock to the heart to stop it, to get the pacemaker cells to re-establish the normal rhythm for the heart. So even though it can't be used with the second or third degree blocks, it should be able to be utilized for atrial fibrillation, ventricular tachycardia, as well as ventricular fibrillation. So in the event that an individual has an event where that person passes out and is not responsive and doesn't have a pulse, that's when we would initiate the call for someone to call 911 and someone to grab an external automated defibrillator, or AED. Now, the external automated defibrillator, that's a mouthful, defibrillators usually turn on when the machine is opened, and there are recorded instructions that will begin to play so that whoever is setting up the AED on the individual who needs assistance will be able to listen to verbal instructions, and they'll tell you what to look for and what to do and how and when to place the electrode pads on the person's chest. And the AED will check the cardiac rhythm and send an electric shock to restore normal rhythm if it determines that there's either ventricular tachycardia, ventricular fibrillation, or atrial fibrillation. It will shock in any one of those three circumstances. It will not shock if there is a second or third degree heart block. So the heart block is the interruption in normal conduction pathway, and that is determined by the conduction that's occurring between the nodes. If we see a first degree partial block, that is a block occurring between the sinoatrial and atrioventricular nodes. Second degree is known as an incomplete block, where some impulses go to the atrioventricular node, others do not. And a third degree or complete heart block, there's no information going from the sinoatrial to the atrioventricular nodes. So again, with the AED, these are machines that are usually found in a lot of areas, either in schools, churches, sometimes even at baseball fields or soccer fields or in gymnasiums. The cardiac cycle is a circular succession of pressure and volume changes that occur within the chambers of the heart. And because it is like a circle, we can pick our starting point pretty much anywhere within that circle. There are some terms with which you should be familiar, one of which is systole, which is the period of contraction within a chamber, diastole, which is that period of relaxation of the chamber, and that usually occurs when the chambers are filling with blood. And remember that wherever there's more volume of fluid, there's going to be more pressure. Think of a hose. If there's just a little bit of water volume going through the hose, there's not going to be a lot of pressure. However, if you turn up the spigot, there's a lot more water that's coming through, hence there's a lot more pressure generated by the volume. And the same thing is really true with the heart when we look at volume and pressure changes. And the cardiac cycle is really important because it helps coordinate and regulate to ensure that blood can be pumped efficiently. We're going to start our story through the cardiac cycle at a point where both the atria and the ventricles underneath are in diastole. And at this point, the atrioventricular valves are closed, and the atria are receiving blood from the lungs and from the rest of the body. And when the blood is done coming back to those holding chambers, the pressure of blood building up in the atria will cause the atrioventricular flaps to open up, and 70 to 80% of blood will flow passively from the atria down into the ventricles. And then we'll see the P wave, where we have atrial depolarization followed by atrial systole. The atria will contract in order to eject the remaining 20 to 30% of blood into the ventricles. And at this point, the ventricles have as much blood as they can hold from the atria, and this is what we call end diastolic volume, or at the end of relaxation for the ventricles, hence the term end diastolic. And we've got the volume of blood that's going to be in the ventricles that will be ejected. It's sometimes also known as preload. And so in order for the ventricles to contract, we have to have that depolarization wave occurring with the QRS wave. Now that we have blood in the ventricles, and this is our end diastolic volume, the ventricles, after depolarizing, which we see on the QRS complex, the ventricles begin to contract. At the beginning of ventricular contraction, the atrioventricular valves close. So tricuspid and mitral valve close to prevent a backwash of blood into the atria as the ventricles begin to contract. Now, since blood is not going anywhere, this contraction is building up pressure, and we refer to this contraction as isovolumetric contraction because the volume of the blood inside the ventricles is not changing. We're just building pressure as the ventricular contraction just squeezes down. And when the ventricular pressure builds up enough to overcome the pressure in the pulmonary trunk and the aorta, that causes those semilunar valves, the pulmonic valve and the aortic valve, to open up, and now blood will be ejected from the ventricles into those larger blood vessels. And despite the fact that the left side of the heart, the left ventricle, has to generate more force than the right to get blood to flow all the way through the body, as opposed to the right side, which is only sending blood to the lungs, despite those pressure differences, there's still the same amount of blood being pumped by the ventricles. And this amount of blood being ejected from the ventricles is called stroke volume. So after the ventricles have ejected their blood, they're going into a relaxation phase. This is where we go into ventricular diastole, and this follows repolarization, which we see on the echocardiograph as the T wave. So after that isovolumetric contraction, we have ventricular relaxation as blood is flowing back to the heart, but is stopped by the semilunar valves. We see a little pressure change that's referred to as the dicrotic notch. I'll show that to you in another graph. But that blood is stopped by the semilunar valves, so no volume is changing. We have isovolumetric contraction and isovolumetric ventricular relaxation. Contraction is systole, relaxation is diastole. As the ventricular volume drops when the ventricles eject their blood, obviously with the volume dropping, that's going to cause a drop in the pressure in the ventricles as well. And it's going to drop below the pressure that's in the atria because blood is flowing back into the atria as ventricular relaxation occurs.